right, we're going to get started again. Keep eating your lunch. These are meant to be a working lunch, so we have two talks for y'all while we're eating. The first one is going to be Dr. Emily Ramirez. Dr. Ramirez is our current epilepsy fellow. She completed her residency here, stayed on for fellowship. She went to the same medical school that I went to, which is a fun fact. And we're really glad that she's going to stay on as faculty after graduating fellowship in a few months. So please welcome Dr. Ramirez.
A little old school. I've got my papers here, so I'll try to shuffle those without too much interruption. I have no relevant disclosures. I have a special interest in neurogenetics, and I have the privilege of talking to you all today on the topic of vitamin-dependent genetic disorders. This particular topic can easily become quite dense and biochemistry heavy. And I know you're all trying to enjoy your lovely lunch, so I'll try to avoid too much Krebs cycle talk today. If you're interested in learning more on the topic, I'll direct you to the Pediatrics in Review article entitled Vitamin-Dependent Genetic Disorders of Childhood, published by myself, Dr. Christina Ulick, and Dr. James Gibson. For today's brief lunch and learn, our learning objectives include understanding the difference between vitamin dependency and deficiency, recognizing signs and symptoms, including red flags, that may suggest a diagnosis of a vitamin-dependent genetic disorder, knowing how to initiate workup and make proper referrals, and being familiar with some of the more common, better understood, or more testable of these disorders. So we'll jump right in. A dietary intake of all vitamins is necessary for proper health. Recommended daily values, or RDVs, are published by the FDA. These differ by age group, but otherwise are standardized. And these are used for labeling, supplement labeling, and labeling of nutrition facts. Vitamins play a critical role in all bodily processes. These include neurologic, endocrinologic, psychiatric, developmental, and hematologic processes. Vitamin deficiency can occur in any person who doesn't get enough of a particular vitamin in their diet, or due to malabsorption, often seen after GI surgeries, or secondary to GI abnormalities. Several vitamin deficiency syndromes are well described. With thiamine deficiency, one can experience beriberi with symptoms of peripheral neuropathy or cardiac dysfunction. Wernicke-Korsakoff, which happens most often to those with alcohol use disorder, results in the triad of ophthalmoplegia, encephalopathy, and ataxia, with or without confabulation. In the setting of B12 deficiency, there's subacute combined degeneration of the cord with selective loss of vibration and proprioceptive senses. And vitamin B3 deficiency results in pellagra with the 3 Ds, dermatitis, diarrhea, dementia. If not enough vitamin D, rickets can occur with bony malformations. And then we all know scurvy, the integumentary and hematologic disorder that can result from vitamin C deficiency. So patients with vitamin-dependent disorders may present similarly to those with vitamin deficiency, but dependency is different than deficiency. These patients require much higher doses of daily vitamins, sometimes as high as 1,500 times the recommended daily value, in order to prevent or offset the symptoms or slow progression of their disease. Most of these disorders are due to dysfunctional or absent enzymes and cofactors that are required for critical metabolic functions. High-dose vitamins, in these cases, act to flood the pathway with its necessary cofactor to overcome that relative deficiency and retain some degree of end product protein production. Some of these diseases are X-linked dominant, with a single mutated X allele being enough to affect both males and females. But most commonly, these are autosomal recessive disorders, meaning an individual has to have a mutation on both alleles in order to be affected. These are more likely to occur in children of consanguineous parentage by virtue of particular allelic variants being more likely to kind of run in certain families, and therefore two parents of the same family being more likely to be carriers for the same disorder. Consanguinity is a deeply rooted social phenomenon in about 20% of the world's population. Mostly, these populations reside in or originate from countries in the Middle East, West Africa, and West Asia and North Africa. And rates of consanguineous marriage are as high as or greater than 30% in Saudi Arabia, Pakistan, Sudan, Iraq, Iran, and other countries. Although these conditions are very rare, appropriate and timely treatment often allows for some degree of improvement or slowed progression. So it's important to be aware of some of the presenting signs and symptoms. In the neonatal population, feeding intolerance, irritability, seizures, and hypotonia are common at initial presentation. Labs will often reveal metabolic acidosis secondary to lactate or other acid byproduct buildup. And this type of presentation obviously should prompt urgent hospital evaluation. In infants and toddlers, presentation can be slower and more subtle. Common symptoms include developmental delays or regression, and vision and hearing problems. For certain disorders, skin and bone abnormalities may be present. And then in the school-aged children and adolescents, movement disorders, psychiatric problems, and megaloblastic anemia may be the presenting signs and symptoms. One particularly hot vitamin-dependent disorder is MTHFR, or methylene tetrahydrofolate reductase deficiency. It's important to remember that this disorder is not caused by the common gene mutation that's all over the internet. These gene mutations on the internet should more appropriately be called polymorphisms or variants, as they affect up to 60 to 70% of the population, with that many being at least, or being heterozygous for these mutations, and then 10% of the population being homozygous, so having two copies of these very common polymorphisms. And it's been shown in those with two mutated alleles that protein function is diminished to an extent, but it's not absent. And people tend to have mildly higher homocysteine levels and mildly lower serum folate levels compared to controls. Patients may come to you after discovering they have an MTHFR polymorphism with the concern for hyperhomocystinemia and a variety of concerns related to inability to methylate their folate. These concerns may include thrombosis, depression, ADHD, insomnia, hormonal cancer, lip and tongue tie, and a variety of pediatric skin findings, such as sugar bug, strawberry hemangioma, stork bite, angel kisses. But the truth of it is that the evidence does not support any of these claims. So what is the actual MTHFR deficiency? Well, it's the most common disorder of folate metabolism. It is also caused by biallelic mutations in the MTHFR gene, but it's characterized by severely elevated homocysteine levels in both the serum and the urine. These patients also have low methionine levels, and they do not have megaloblastic anemia that's seen in some other disorders of folate metabolism. The presentation is often seen in infancy, but can be as late as adulthood, with the severity of the disease directly related to the age at onset. Infants typically present with epileptic encephalopathy, hypotonia, and weakness, leading to early death. And in older age groups, the presentation is variable, but can consist of developmental delay, seizures, ataxia, weakness, thrombosis, or psychiatric manifestations. MRI of the brain here reveals white matter degeneration and delayed myelination. And unfortunately, once neurologic involvement is clinically apparent, the prognosis is poor. Patients are managed with supplemental betaine, which shunts excessive homocysteine through an alternative metabolism pathway. And if diagnosed prenatally, such as in high-risk families where there are known cases, maternal betaine, prenatal maternal betaine, provides the best chance at improved outcomes. Additionally, 5-MTHF, or bioavailable folate, hydroxycobalamin, and folate in other various forms works in combination to reduce the homocysteine levels for these patients, as well as increasing CSF folate levels and methionine levels. Last, I'll just give a brief overview of some of the more common or better described vitamin-dependent disorders. First, in the vitamin B5-dependent pantothenate kinase-associated neurodegeneration, or PCAN, features include movement disorder, failure to thrive, and retinopathy. Certain cases can have a psychiatric and speech problems. The MRI here reveals the pathognomonic eye of the tiger sign, which is symmetric central globus pallidus T2 hypointensity or darkness, with a rim of T2 hyperintensity or brightness, which is related to iron deposition. Pyridoxine-dependent epilepsy presents most commonly with neonatal seizures that are resistant to anti-epileptic medications such as phenobarbital and Keppra. All patients with drug-resistant seizures of unknown etiology should undergo a pyridoxine trial, which is ideally performed in the ICU with high-dose IV pyridoxine and EEG monitoring. Treatment of pyridoxine-dependent epilepsy is with lifelong pyridoxine supplementation. Also sometimes includes a lysine-restricted diet and supplementation with folinic acid and arginine. Patients with B6-dependent classical homocystinuria present in childhood with seizures, movement disorder, developmental delay, as well as skeletal and ophthalmologic abnormalities. They often have a marfanoid habitus and can have lens dislocation. They unfortunately tend to have a poor response to supplemental pyridoxine, but concomitant therapy with betaine may help improve their risk for thrombosis. And vitamin B12-dependent disorders such as homocystinuria, another form of homocystinuria, and methylmalonic acidemia, they result from aberrant intracellular B12 processing, which causes both central and peripheral demyelination, resulting in sensory and motor neuropathy, spastic paresis, and cognitive dysfunctions. Lactic acidosis and seizures are also possible with these patients. Early high-dose parenteral hydroxycobalamin and other supplements have been proven to prolong lifespan and improve both neurologic and hematologic outcomes. And lastly, A-beta lipoproteinemia, it's a mouthful. It's a disorder of dysfunction of a protein that's required for lipid absorption from the gut. Its absence results in deficiency of all lipid-soluble vitamins, as you might imagine. Symptoms include loss of color and night vision and retinitis pigmentosa related to vitamin A deficiency, bleeding tendency due to vitamin K loss, and then ataxia, movement disorder, peripheral neuropathy related to vitamin E deficiency. Management includes dietary fat restriction with supplementation of all essential fatty acids and fat-soluble vitamins. And so in summary today, we discussed the difference between dietary vitamin deficiency and genetic disorders causing dependence on high-dose vitamin supplementation. We discussed that most of the disorders are inherited in an autosomal recessive pattern, making them more commonly affecting patients with families with consanguinity. We summarized some of the more common presenting signs and symptoms by age group. And we discussed some of the vitamin-dependent disorders, including MTHFR, in which specific biallelic mutations cause extremely elevated levels of homocysteine, low folate and methionine, resulting in thrombosis, seizure, developmental, and psychiatric problems. I very much appreciate your attention today, and I welcome any questions.
Hi. Just to clarify, these are mostly screened for in the newborn screen, right? Tests when they're.
Quite a few of them are, not all of them, but yes, a number of them are. And I should have included a list for you, but yes, a bunch of them are. So
Okay.
ideally, they would be detected there, but of course, we know that it's not always accurate.
My other question as a follow-up is, so when new immigrants arrive in the country, especially from areas where these diseases are prominent, is there an age where you recommend that this screening be done, like a newborn screening, even though they're not born in U.S. and they weren't given that option?
Oh, that's a great question. I don't know that there is a guideline to indicate that. It seems as though, so what I would think is that a majority of these disorders are going to present in the neonatal or infantile and even early childhood age range. I think that if a patient hasn't had a newborn screen because they were born but are at high risk, don't have any symptoms yet, unless there's known family history, I don't think that a screening process is necessary, but rather a low tolerance or a kind of a low threshold is, I guess, the words I'm looking for, to refer as necessary if you see any potential signs or symptoms. Thank you.